Hello everyone, welcome to NAC OSCE preparation course. My name is Dr. Naila Ijaz. I'm from STARMED Medical Education Program. This video is created for education purpose only. Our today's topic is differential diagnosis of chest pain. Let's begin with a common case presentation. We have a 50-year-old man who presents with chest pain of 45-minute duration that started after exercise. What could be the differential diagnosis? We will talk about causes of chest pain. They can be categorized as acute and chronic. The acute causes comprise of cardiac versus non-cardiac. Among the cardiac causes, we have acute coronary syndrome that covers unstable angina, ST elevation MI, and non-ST elevation MI. Other acute causes can be cardiac arrhythmias, aortic dissection, or pericarditis. Among the non-cardiac but serious causes of chest pain are tension pneumothorax and pulmonary embolism. Chronic chest pain can be due to multiple reasons, such as stable angina, respiratory causes, muscular and chest wall reasons, gastric reflux, or psychological. We are going to talk about the acute coronary syndrome in detail. The presentation is usually retrosternal chest pain that radiates to left arm or jaw. It lasts longer than stable angina and is continuous. It can be triggered by exercise or emotions. It is very important to discuss about the risk factors of acute coronary syndrome, which may include hypertension, diabetes, hypercholesterolemia, smoking, and positive family history of heart disease. The main investigations which aid in the diagnosis of ACS are electrocardiography and cardiac enzymes. If such a patient presents at the setting of a clinic, our main goal is to transfer them to emergency after giving them antiplatelets and nitroglycerin. In hospital, the treatment focuses on revascularization. Chest pain can also be due to a condition called pulmonary embolism. As the name indicates, there is an embolus or blood clot that gets dislodged in pulmonary circulation and it can be life-threatening. Risk factors of pulmonary embolism are hypercoagulable states, deep venous thrombosis, immobilization, post-op patients, or after trauma. We can diagnose this condition with the help of pulmonary angiogram or ventilation perfusion scan if the former is contraindicated. Management involves admission to the hospital and administration of anticoagulation. Another serious cause of acute chest pain and shortness of breath is something called tension pneumothorax. It can happen spontaneously, or the predisposing factors can be someone with underlying lung condition, COPD, a smoker, or a person with positive family history. Diagnostic criteria involves hyperresonant chest, deviation of trachea, and diminished breath sounds on the affected side. Chest X-ray can aid in the diagnosis. The management focuses on urgent needle thoracotomy. Pericarditis can also present as chest pain. It is the inflammation of the covering of the heart. The pain is sharp or dull and is relieved by leaning forward. Risk factors include post-viral infection, after MI, or uremia. Pertinent investigations are echocardiography and ECG, which can depict diffuse ST elevation in all the chest leads. It can be treated both inpatient or outpatient, depending upon the severity of presentation and comorbidities. The mainstay of treatment is NSAIDs and taking rest. Lastly, we will discuss about a non-cardiac but very common condition that can also present as chest pain, which is called gastroesophageal reflux disease. It is very important to rule out cardiac causes once we are suspecting GERD. Management comprise of modification of risk factors, exercise, and medications such as proton pump inhibitors. This concludes our today's presentation. Hopefully, now you will have an idea about chest pain differentials. Thank you so much for